Please welcome Keith Grundy, Senior Vice President and Regional Manager, Healthcare Financial Services for Wells Fargo Bank.
Well, thank you. It's a pleasure to be here today. I'm sure that everyone would continue to have discussions around the Giants and the 49ers and not to discuss healthcare. But given that healthcare spending has increased from 5% of GDP in 1960 to 18% in 2012, and that annual healthcare spending is now almost $3 trillion, there's a good reason to be discussing healthcare. And this growth in healthcare spending, which was coupled with a very high number of uninsured, gave rise to the Affordable Care Act, or ACA, which we'll be discussing today. The ACA became law in March of 2010. Certain provisions of the act are already effective, and the individual mandate, which is one of the more controversial provisions of the act, becomes effective in January of 2014. So today we've got a great panel of speakers who will discuss how their organizations are developing new and innovative approaches to healthcare delivery in response to the many legislative, regulatory, and financial challenges. So please welcome our first speaker will be Michael Blasek. Michael is Executive Vice President and Chief Financial Officer for Dignity Health, which is an integrated delivery system, $10.5 billion in revenues, which now operates in 18 states. Dignity's hospitals date back to 1856, and Dignity Health currently has 60,000 employees. And given the earlier presenters, I'd be remiss if I failed to mention that Dignity Health is the official healthcare provider of the San Francisco Giants. Our second speaker is Dr. Ken Bradley. Ken is the Chief Medical Officer and Senior Vice President for Safeway. With $41 billion in revenue and 178,000 employees, Safeway is one of the nation's largest food and drug retailers. Ken's extensively involved with Safeway's broad range of healthcare initiatives, including wellness and prevention activities for both consumers and employees. He comes to Safeway after a distinguished career in the U.S. Army, where he served as Chief Medical Officer at both the division level and for TRICARE in Europe. And then the final speaker is Paul Markovich. Paul is the president and CEO of Blue Shield of California. Blue Shield of California is a not-for-profit health plan with $10.5 billion in revenues and 3.3 million members. And Blue Cross of California serves the commercial, individual, and government markets in California. And sticking with our sports theme, Paul played Division I hockey at Colorado College. So first, we're going to hear some remarks from Paul, kind of setting the stage on healthcare reform, and then we're going to have a panel discussion about the fundamental changes that are expected in healthcare delivery.
Thanks, Keith. Good afternoon, everyone. Blue Shield of California is also a proud sponsor of the Giants, and one of the perks that I got from that this week was I got to be a ball dude at the Monday night game at the Nationals, and it actually reminded me a little bit of what it's like to be in insurance, because if you know, these are the folks that sit on the side, on the foul lines, on little stools when it's freezing cold, and then wait for maybe one or two of 300 odd pitches to be a scalding line drive that they then try to go pick up. And generally, there's no news coverage of that, no announcer coverage that's good if you're a ball dude, right? It's not like you pick one off and they say, sign that guy up to back up Brandon Crawford. It's generally you go out and you make a complete fool out of yourself, and then Kruk and Kipe sort of go on and do the replays. So it's like no news is good news, and that's sometimes what it feels like to be in health insurance, right? If you're not getting covered, generally, it's better than getting covered. But I also want to make mention, we made an announcement earlier this week that Leon Panetta, who is the next speaker, is going to be rejoining the Blue Shield of California Board of Directors. And we're thrilled about that. I personally am thrilled about it. And when I get asked by my friends and family how we managed to pull off that coup, I tell them a secret that perhaps the CIA doesn't even know, which is that begging is definitely underrated as a strategy in these situations. I just want to thank the Bay Area Council and my colleagues up here on stage. I'm just going to spend a few minutes teeing up 3 themes that I think are worthy of discussion. First, it's a moral and financial imperative that we get everybody health care coverage. Second, we need to make health care sustainably affordable for everyone, or we're going to bankrupt ourselves as a society. And third, we can't solve this affordability crisis alone. There's no one entity, private or public, that really can solve this on its own. It's too big and it's too complicated. So I think those are the 3 themes, and I'm going to expand on each of them a little bit before we dive into our conversation. On the first one, I think it's both morally and financially imperative that we get to universal health care coverage, because it should be unacceptable to us as a society that so many people are an illness or an injury away from personal bankruptcy. And the leading cause of personal bankruptcies in the country is healthcare costs. And when you have more than 7 million Californians and 50 million Americans and counting in that uninsured pool, it's simply not financially sustainable for the shrinking number of people who are commercially insured to be subsidizing a growing set of people who are uninsured, which is effectively what has been happening for years. And so it's wherever you lie on the political spectrum and whatever you think about the Affordable Care Act, it affords us the best opportunity in the near future to dramatically reduce that number and put the entire system on a sustainable path. And fortunately, in California, I managed today to participate in the press conference with Covered California, which is the California Exchange. We've gotten off on the right foot here in California, because the California Exchange announced today that 13 health plans, including Blue Shield of California, are going to be offered on the exchange, and that the prices are going to be much lower on average than many experts were predicting in California. And so it should give the exchange a chance to be successful in California. So first, we need to get everybody covered. Second, we need to make it affordable. You've probably looked at the numbers, federal, state, and others, but just a few facts that you may find interesting. There's an analysis that was done about Medicare and Medicaid, and if you extrapolate out status quo, those 2 programs, within about 60 years, they become as large as a percentage of GDP as the entire federal budget is today. They become about 20% of gross domestic product out in around 2070 or 2080. And clearly, that's not something we can afford as a society. If you look at commercial employers, it costs more to pay for the health benefits of a Silicon Valley engineer than it does to hire one in India today. And Starbucks pays about as much for health benefits as it does for coffee beans. If you look at the total all-in cost of the average family of 4 in California, they would have to spend, if they paid the whole bill themselves, over 25% of their gross median income, not take-home pay, gross income, pre-tax, just to pay for health care. Government doesn't have the money, businesses don't have the money, individuals don't have the money to keep paying trends that greatly outstrip wage inflation and price inflation. So we have got to figure out how to make it affordable. And then finally, one entity can't solve this. Every one of us is a part of an organization. We've worked closely with Dignity Health on ACOs that have taken trends down to 3% per year for a substantial population. We've, as a not-for-profit, capped our net income at 2% per year and given back over $500 million the last 2 years, when we've made more than that, back to our customers, back to the community. We, like Safeway, have done a number of things on wellness for our employees. We've tried to do a lot of things. We're all proud, all of us, of our organizations and what we've done, but this is far bigger than any one company. We need to figure out solutions together to make this work. So those are the 3 themes I think are worth discussing in more detail: getting everybody covered and making health reform work, making sure we make quality healthcare affordable, and figuring out how to work together to make that happen. So thank you, and I'm looking forward to our conversation.
Thank you, Paul. I certainly appreciated the comment about wherever you are on the political spectrum about healthcare reform. In the lead up and the passage to it, I met with a lot of healthcare executives, and some were for it, some weren't for it. But I think to a person almost, they agreed that the current trajectory was unsustainable, and that whether we had reform with a capital R or reform with a small r, reform had to happen. That we just couldn't stay on the track that we are. But one of the goals of reform is to move the system away from a fee-for-service based model, which is still the predominant model. So I'm going to ask Michael to address how moving away from the fee-for-service model, how that can be navigated by systems like Dignity Health, and what effect that might have on revenues and margins.
Thanks. I have to echo what Paul began with. It is, in our view, at Dignity Health, egregious that we had 47 million Americans without health care coverage. It's just wrong. I realize that everybody has a different point of view about it, and that's one of the great things about the society we live in. Having said that, we also felt it was pretty unacceptable that we're at a point where we're spending approximately 18% of the gross domestic product, and we're really not driving value. We're very cognizant of the fact that our employers need to be competitive on an international basis, and we see it as one of our responsibilities to help ensure that employers are able to do that. That's going to require a fundamental change in the way we deliver health care. We know that. We knew it when we set about it. I also agree with Paul that it's going to take strong partnerships, and we're so thankful that we have the relationship that we do with Blue Shield today. We've made some important experiments in looking at how we can make those changes. As Paul mentioned, the accountable care organization that we did with CalPERS and Hill Physicians and Blue Shield showed that the experiment can work, and we know we can go further. We must reduce our costs, but we need to move away from being a cottage industry. And it's sort of shocking to think that, because when you drive by some of today's highly efficient technology hospitals, you have to wonder, how is that a cottage industry? Well, the fact is most of healthcare is paid for on the basis of piecework. And we get paid for every little thing we do. We need to move away from that, and we need to move towards payment for value, making sure that we're getting the proper outcomes, making sure that we're doing the right thing, making sure we're accomplishing it in the right setting, and making sure that we're accountable for the cost of providing that care.
So, well, maybe do either of you want to?
Well, the only thing I'd say is that you have to allow for providers, dignity included, to figure out how to get paid to do the right thing. And in fact, that is what we did in our partnership and what we've done in multiple ACOs, which is by creating a budget and targeting a budget collectively for the physicians, the hospitals, and the health plan. When we beat the budget collectively, we all get rewarded. And when we don't, we all get penalized. And so in effect, Dignity Health is getting paid to get readmission rates down, when in fact in the fee-for-service system, it's the exact opposite. And boy, have they done a great job of that in partnership with Hill and with Blue Shield. But it's amazing when you can get everyone on the same side of the table and get off that fee-for-service model, what's possible.
Do you want to address more the partnership between Blue Shield, Dignity, or among Blue Shield, Dignity, and Hill Physicians, and the move to creating more of an integrated model? And also whether, the logical end game is full integration, sort of a la Kaiser?
Well, we have referred to it as virtual integration because, as I've said to Lloyd and others, I don't know how to run a hospital. And so the idea of owning one, I can't imagine it would be run better with me owning it, or perhaps vice versa. Maybe Lloyd knows how to run a health plan. He probably knows how to run a health plan better than I know how to run a hospital. But we are all good at what we do, I think. Very good at what we do, and we understand how it works. So if we could, in this model, if you simply say, here's our budget, like with everybody else, you're trying to hit a price point. If you were inventing a smart cell phone to go compete with the iPhone and the Android, and whatever else is out there. You'd put a team together, develop features, and say, put together a phone that can do these things and hit this price point. And that's what I call price-based costing. That's not how health insurance has worked, but that's how our ACO works. We're saying we want to hit this price point, we want to hit this cost level, and we sit down together, look at the data, and figure out how to get cost out of the system and put it back into the price. But now, Dignity, Hill, and Blue Shield all get rewarded for improving the quality of health care and reducing the cost, which is the opposite of what we experience, as Michael was saying, when you get paid for each piece.
Clearly, one of the issues in the cost of health care, you'll see different kinds of statistics. One being, that the top, 4 or 5 chronic diseases, account for, 70-something% of total healthcare spending. In another way, it's looked at and it produces similar numbers. If you look at what's referred to as the frequent flyers, these are individuals who are in and out, or get hospitalization, generally coming through, the ER. And again, they would account for, 70 or 75% of total health spending in any given year. So how do you design, programs and incentives to actually improve the long-term health of employees, subscribers, and their families? And maybe Ken can
Sure
take a
thing.
shot at that.
It's kind of interesting sitting between these two gentlemen. Safeway began its own internal reform in 2005 with a big idea that we can, in fact, create a value-based incentive design that looked at and encouraged healthy behavior and rewarded that, as well as was thoughtful in its programs to help individuals in their health journey, but also providing them tools. And part of the affordability, which I haven't heard yet, is this issue of transparency. Right now, healthcare continues to be opaque. We don't really know what the cost of healthcare is until after we get that bill. And I think as we have this discussion around what it is that we need to have, we need to also think about the fact that it was said earlier today, I think, in the social media, that the whole notion of if it's not a good time to be a control freak. And I think this control over the data around quality, around customer and client experience, around cost, we have to just let it go. Let individuals begin to become more knowledgeable and trust that they can make good decisions. The same is true with their own health measurements. And I really believe this person-centric view and empowerment of individuals with knowledge about their health, they're seeking after this information already. We can come alongside them. As an employer, we're self-insured for a portion of our members, and that's what we believe. We believe in the power of the individual to make good choices and providing them the tools to do so. But part of this equation, I think, in affordability, I'd be curious, Paul, your thoughts, but is around the transparency piece.
Oh, absolutely. I agree with that. And also just, there's two populations who have the biggest impact on healthcare. They are the members or the patient and the choices they make. And then the providers, the clinicians that are providing the care. They are the ones that their choices drive healthcare costs and healthcare quality. So influencing those choices, getting consumers engaged is helpful. Not only helpful, but necessary to get there. It also obviously has limitations. You don't want someone who has a heart attack in an ambulance grabbing their phone, shopping for the best. You just get to the hospital, right? Take an aspirin and get to the hospital. So there are plenty of health conditions where consumer shopping has its limitations. But consumer engagement on wellness in particular, and on a lot of discretionary and elective services is a big part of the equation.
Sure.
And having transparency on data and engagement of consumers is going to be, I think, crucial.
Yeah, and I would say, I've had 50 years to plan my colonoscopy, so there are services that
And it sounds like you've taken every one of those years to do that.
Yeah. So there are services. So I think this notion of an emergency room, I get it, but I think there's also this responsibility to think thoughtfully around, to be thoughtful around those things that could be areas for our own knowledge, and I think that this belief in not just the care equation, but the health equation. I mean, we as a nation have to address this issue that we have to be a healthier nation. And that is a very complex issue. It's one that's it's going to require everybody in this room to think about the built environment, the choice architecture, the education that we provide, all those different things that we collaboratively, to your third point, we can work together to really address the health piece of the equation. And how do we incentivize that in our healthcare delivery system? I think it's critically important.
Yeah, if I could just jump in for a moment, I think that is so true. And as providers, we need to be able to embrace that, and we need to restructure it. So when we go back to partnership, we understand that we have to change the way we pay for healthcare. Physicians ought to be able to be compensated to monitor biometric devices that provide feedback. I'd try to get it out right now, but how many of you in the audience have Fitbits? Yeah, a fair number of you. I've got mine in my pocket. It's giving me constant feedback, and it's beginning to have an effect on making some behavior changes. But we've got to be able to put our money there. And as employers, I think you have a big role in that. How often are we putting together benefit plans that require that our employees make decisions each year? And when you think about that, how well do you think we can all do in being able to make those behavior changes? I think we have to fundamentally restructure, and it's not just the partnership we have here, but it's a partnership with employers as well.
Well, some of the criticisms levied against the Affordable Care Act was, that it really was just, expanding the pool of the insured, and maybe wasn't doing enough to, address more fundamental issues. So is the Affordable Care Act, is that just round one? What does the panel think about the future for both legislative and non-legislative changes, and over what time span might that play out?
Yeah, listen, I think a bill this large and this complex, every single one of us could sit down and tell you what we'd like to change in it and where we think there's shortcomings. But we live in a democracy, and you go through a political process, and there's no such thing as a perfect bill of this scale. I'd also say that some of the same people who are kind of criticizing the ACA for a lack of controlling costs are the same ones who are criticizing it because it's government overreach. And I always found that a little perplexing. You don't want them involved, but you want them more involved. So there are fewer components in the bill. The bill's much more about coverage and much more about rules changes in healthcare coverage. And there are opportunities in Pioneer ACOs to do some cost containment that are there, but it is less about that, I agree. I also think it's up to us to drive that affordability through these partnerships like the ones Michael and I described. And I'm very comfortable having the private sector take the bull by the horns together to try to make a difference in that area.
I would agree. I think that the other aspect of it's going to be a stepwise. There's going to be changes. This is the healthcare reform is the forcing function. It was the wake-up call. It's really going to happen. Now we've got to roll up our sleeves and now work with this. But I think some of the big ideas is, well, how do we even deliver healthcare? I mean, why is it that I'm a physician? Why is it that I, as a physician, have to see everything? That the expansion of the scope of practice across different individuals and professions, I think, is an area. How we deliver medicine with telehealth, and how we there's technology increasingly where we have more of the quantified self and technology that's going to allow individuals to communicate with their provider increasingly through email, internet. So there's ways for us to reduce cost by thinking outside of our traditional mechanism of healthcare delivery as well. And I think that's going to be a tremendous opportunity.
When you think about every major social movement that's occurred in the U.S., Social Security, it wasn't perfect the day it went out. It took years to sort of migrate to a place that it was really effective. In fact, with Social Security, we're still having conversations about how we make that affordable and looking at the mortality of individuals and the longer lives. I think the same thing is going to happen with this, but I think the speed of the change is going to be much faster. As consumers become more educated, as they're increasingly part of the economic equation and decision making, as health plans and providers need to be able to be competitive to respond to that, that change is going to happen at a very rapid rate.
And how do you see, the impact on both integration and consolidation? How do you see that, playing out? Employment of physicians.
Well, that's a great question. The regulatory framework in healthcare, I think, is regulated just under nuclear power plants, and just ahead of banks, which are going through the same thing now. So welcome to the party. But most of the regulatory framework was put in place when we had a fee-for-service system, and the whole guardrail was to try to keep payments, incentives to not inure to physicians and in other kinds of practices. That doesn't work in a system that's trying to change with the speed that we're trying to change. So whether it's Stark laws or anything else, I think we've got to be able to step back, and that regulatory apparatus has to be able to change with it to allow that to occur and be effective.
So if we came back here to this venue in 5 years, what do you expect we'd see if we were describing the healthcare landscape?
I think you're going to see.
We might be on the same payroll,
yeah,
Paul.
That's right. We're both going to be reporting to Lloyd. That's right. No, I'd say we're going to have a lot more people covered. I mean, I think it will be a bumpy ride to implement healthcare reform, but we will implement it, and we have a lot more people covered. We will have trends down much closer to, if not at, CPI and wage inflation. And I think you will have more consolidation at all levels, health plan, hospital, physicians, physician groups, partly because of the regulatory environment, in that the fixed costs keep going up in a business where you have to comply. And also the intensity of getting into making behavior changes is expensive, and figuring out how to do it. I think there's going to be fewer players, but that's okay if it works out. It should be healthy, and there'll still be plenty of competition.
2018 is when the large employer, several things start to happen in 5 years. So you've got the tax issue, you've got the opportunity for large employers to enter the exchange, if I remember the timeline correctly. Mm-hmm. And so I think in 5 years from now, it'll be interesting, and it'll be based on how well these individuals are able to execute on this notion of a marketplace and really make healthcare affordable. From an employer's perspective, I believe we're going to find increasing number of employers committed towards this belief that wellness and health is a critical component of not just the healthcare cost equation, but in productivity and overall well-being as a good thing and something we should support. So I see that happening as well. I also think that we're going to find an increasing acceptance of non-traditional mechanisms of care that are going to now become traditional or commonplace. I think that's going to happen in 5 years as well.
I think we're going to see a lot more standardization, and I think consumers are going to be able to expect a lot higher level of quality. So I think that for one to think that when you're trying to become far more cost efficient, I don't believe that the number of things that we do for a patient actually increases the quality or the outcome. And I think that we are going through a very exciting time. I feel really blessed that I'm able to go through this kind of change. It's one of the changes. It's one of the most fundamental changes that we've seen in American society. I think it's an exciting time, and I think if we all work together, we're going to accomplish great things. And I think the Bay Area is a classic place that can sort of foster that kind of change and be a leader.
Great. Well, we are running short on time here. Just my observation would be, in the years I've been in healthcare, people were predicting something would happen, and it certainly seems that we've turned that corner. And so I think that the vision that was shared here, is likely to play out. I don't think we're going to come back in 5 years and see sort of the same old, where things are, running along that trajectory. I think we've gone beyond that, and it's too late to turn back. Unfortunately, because this is something that we could have addressed sooner. So thanks everyone for participating. Hope you enjoyed.